we don't have a clicker, I'm sorry, so I'm going to awkwardly sort of straddle the edge of this thing while I get clarification this morning. Morning, everybody. I'm Dan. This is the core content series, which is what they suck our CMI is integrating. This morning I want to talk, we can start off with a case. We got a 60-year-old guy. He's got diabetes. He's coming in because his foot hurts. It's been going on for about 1 month. He's got totally normal vitals. And so you get right to the chase. It's a fast-track patient. Take a look at the foot and you see this. So you look at his foot, you look at that, and he says, you know, doc, that's been looking like that for a while, but what's really bothering me is what's underneath. So you take a look down there, and you see this big, nasty ulcer underneath his foot. And being the diligent resident that you are, you measure the area of the ulcer. And you see that it's about 2 centimeters by 2 centimeters. And then you say, well, you know, I'm worried about this. Maybe I should probe and see if I can touch bone at the bottom of it. And so you're a little over-enthusiastic. you're an enthusiastic intern, and you get that bone, but you just go a little bit far. You send some labs. Labs are pretty bland, pretty normal. And then you send a couple of other tests. You send a sed rate, which comes back high. And you send back a CRP, which is high. And you say, I know what this is. And you order an x-ray, and the x-ray looks like this. Does anybody know what our diagnosis is this morning? Louder. Osteomyelitis. So this morning we're talking about osteomyelitis. So for osteomyelitis, there's a couple of things that I want you to know about osteomyelitis that I think are very important. And before we get to the diagnosis and treatment of osteo, I want to go over just some of the core pathology of how osteo works. One of the most important things about osteomyelitis is whether it's coming from outside or inside the body, whether it's hematogenous or exogenous, and then whether it's acute versus chronic, because this is going to make a big difference for our treatment decisions about whether to give people antibiotics and do them or not. Osteomyelitis is defined as an infection of the bone by Henry's principles of internal medicine. Very complicated definition. Generally speaking, so osteomyelitis can infect any bone in the body. You can get osteo of the calvarium, you can get osteo of the mandible, but the vast majority of osteomyelitis that we're going to diagnose in the emergency room is going to happen either in the spine, the long bones, or in the feet. And for us in particular, who deal with a population that has a lot of burden of diabetes and vascular disease, the feet is where the money's going to be for us. Now before I keep going in this lecture, I think it's important to know there's a difference, a pretty big difference between the pathophysiology and diagnosis and treatment of osteomyelitis in children and adults. And osteomyelitis in children can be a lecture in and of itself, so I'm really going to focus on osteomyelitis in adults. But realize that osteo in children is actually a pretty different disease, and you can't necessarily apply everything that I'm saying here to kids. So osteomyelitis, like I was saying, can come from either inside the body or from outside, either hematogenous or exogenous. And if it helps with an analogy, it's sort of like the difference between Battlestar Galactica, where you have bad guys that are part of the crew, and they're like infecting the team, versus Star Trek, where all the crew are the good guys and all the bad guys are coming from outside. I don't know if you guys watch. So, hematogenously spread osteomyelitis, meaning that it's coming from somewhere inside the body, the bacteria is coming from inside the body and seeding to the bone. Like other kinds of osteo, can infect any kind of bone, but the most common is the spine. This is a cross-section of a spine that had an osteomyelitis abscess. And you can see that it's mostly affecting the vertebral body, but also invades the disc space on the side there. The lumbar spine is the most common place to have osteomyelitis of the spine. About 60% of cases that come in that are going to get diagnosed with osteomyelitis of the spine end up being the lumbar spine. Another 30% or so are thoracic. However, there's a caveat there, which is that if you're talking about tuberculosis, then about 75% of the cases of tuberculosis of the spine are going to end up in the thoracic spine. Does anybody know the name of this disease for our chocolate? Potts disease. I heard it over there. Somebody catch this chocolate. Pass it around. Potts disease is tuberculosis, osteomyelitis of the spine. And the reason that it affects the thoracic spine is because a lot of the lymphatics and the pleural-based infection of tuberculosis spreads very easily to the spine. directly. And so it's not actually truly hematogenous. Cervical osteomyelitis, it counts for only about 10% of the cases of osteomyelitis of the spine, but it's about 50% of the complications. Anybody spot the abnormality on this MRI? Maybe the arrow sign would help. So that's an epidural abscess. This is the big feared complication of osteomyelitis in the cervical spine. Leave it to be that anybody who comes in with back pain and a fever, we have to think about osteomyelitis. Anybody who comes in with back pain, neck pain, and has risks for having bacteremia, either they have known endocarditis, they have an indwelling line, these are people we need to think about osteomyelitis. So when something is hematogenous, it means that the bacteria is coming from somewhere. About 50% of the time that people come in with hematogenous osteomyelitis, we find a source for it. The other half, we never really find a source. The most common source is this right here. So right where that tricuspid valve should be, there's a cauliflower of probably Staph aureus there. Also the infected permacaths, we've seen more than our share of these. People come in with long-standing permacaths on their chest wall. Other kinds of lines, PICC lines, mid lines, people come in with those lines, chemoports, those can all get infected and cause hematogenous spread of the bacteria that will go to the bones. Pyuria. So for whatever reason, amongst the various types of infections that people commonly get, pyuria is more likely to cause bacteremia than, say, pneumonia. And just other kinds of bacteremia. Do you know bacteremia is a thrash metal band? It's these guys right here. They're terrible. Don't listen to them. They're out there doing their thing. So from the microbiology standpoint, hematogenous osteomyelitis is a slightly different microbiology, and this is important for treatment than the exogenous osteomyelitis. Most common bug, any guesses? Staph aureus, yeah, the gram-positive cocci clusters. Second most is another very common player, Streptococcus. Usually strep pyogenes, but also strep bovis, group B strep, viridans if you have endocarditis. And also this guy. So did you guys know that you can get plush toys of all sorts of different bacteria? This is a gram-negative rod, very common one, has multiple flagella. Any ideas? E. coli. It's an electron micrograph. All those little flagella. I thought that was cool. So we talked about hematogenous, meaning that it's coming from inside the body and spreading to the bones. The other major way, and honestly the most common way that people get osteomyelitis is because bacteria is coming from the outside world and getting through the barriers that are between the bone and the outside world. And this can happen a couple of ways. There's a couple of obvious ones. Surgery is a pretty obvious one. Our friends, the orthopedists, who are going to be doing operations on bones, can certainly introduce bacteria into bones. And we've all seen that complications of surgery can involve osteomyelitis. And this is really important if there's any hardware involved in terms of what our disposition and treatment for these people are. Also trauma. Anytime you have exposed bone, that's a place where bacteria can get to the bones. This person's probably going to get both surgery and trauma. But far and away the most common way that we're going to find osteomyelitis presenting is with people who have chronic vascular and neuropathic insufficiency of the lower extremities. And the chronic breakdown of the skin because people can't feel their extremities, and also just because they have poor circulation, is going to make it much, much more easy for bacteria to get from the outside to the inside. And usually it starts with a local infection of the soft tissue, forming an ulcer, which then goes on to create osteomyelitis. The bacteria and the microbiology of exogenous osteomyelitis, like I said, is a little bit different. We've got our common players. This is staph, which is very cute. There's strep. In diabetic osteomyelitis in particular, Pseudomonas plays a big role. I don't have a good reason why Pseudomonas in particular loves diabetics. I think there is a specific microbiologic reason that Pseudomonas loves diabetics, but it's a very common player in diabetic osteomyelitis. But more often than not, this is going to be a polymicrobial infection. So you have to be aware that when you're treating the lower extremity osteomyelitis of diabetics, you're treating a lot of different bugs all at the same time. So the other big important point before we get on to the diagnosis and treatment is whether something is acute or chronic. This is a really important point, and it is frustratingly not defined. So if you try to look up what is the definition, like what's the cutoff point between an acute osteomyelitis and a chronic osteomyelitis, there's really, nobody will put their finger down and say, like, this is the time period when it does. But it's super important because acute osteomyelitis is potentially curable with antibiotics alone. Whereas chronic osteomyelitis almost always needs surgical debridement. When does an acute osteomyelitis turn into a chronic one? Well, you know, there's some clinical signs that we can use to tell. If it's been treated already and it's returned or gotten worse, then it's considered chronic. If it's, quote, more than a couple of weeks, then it's chronic. If it's associated with a draining sinus tract, then it's chronic. Other than that, it's very hard to get a more firm definition from any particular society or group about what's acute versus what's chronic. So how do we take somebody in the emergency room and say, I think you have osteomyelitis, I think you're the one who's got it. So there's a lot of different ways that people have looked at this before. I think there's a great review article in the JAMA Clinical Rational Exam Series. If you have time to look at it, it's only like 3 pages long, and it's basically a review of all the different literature about the diagnosis and treatment of osteo, and I really recommend it. What it says is there's a couple of hard signs, clinical hard signs, that you can look at and say this is very likely to be osteomyelitis. The first one is exposed bone. If you see exposed bone, like that nice metatarsal there, then you have a very high likelihood of having osteomyelitis at that point, at the base of an ulcer. So high that the likelihood ratio is about 9.2. Now, the absence of exposed bone is almost useless in excluding osteomyelitis. So it's a very poor negative likelihood ratio, or poor negative predictive value. But it's got a great positive predictive value. The other very good positive predictive value finding, but poor negative predictive value, is the size of the ulcer. If the ulcer is more than 2 centimeters squared, then it's very, very likely to be osteomyelitis. Now remember that what's the number we would like for a likelihood ratio? 10. Like 10, and a negative likelihood ratio? 0.1. So we can see that this is approaching a good test in terms of its positive likelihood ratio, but it's still pretty far away from being a good negative likelihood ratio. And then there's this thing, which is probably going to be the one that you're most likely to get tested on the boards, which is called the probe to bone test, which I found this kind of creepy video of. Sit back, enjoy this. Basically what a probe to bone test is you're going to get a sterile metal instrument, and this is metal in honor of Dr. Dennehy, who likes the clink. So what we're going to do here is we're going to take the sterile metal instrument and probe to the base of the ulcer. Now if you can see bone at the base of the ulcer from the outset, there's no point in doing this. You're done. But if you can't see bone, you can still sometimes palpate bone with a metal instrument. And so palpating down to the base of the ulcer, sometimes you can feel the bone. If you can feel the bone, then it's a positive probe to bone test. If it's negative, then it's a negative probe to bone test. So creepy. So the probe to bone test has pretty similar likelihood ratio characteristics, but a little bit better negative predictive value. Overall, this is the one that you're probably going to most likely get tested on in terms of boys is the probe to bone test. Another thing that people say a lot is if the ulcer is inflamed, if it's got a lot of erythema, if it's got a lot of drainage, that means it's got osteo. It turns out that's not true. So we take a look at this original image that we have. We take a look at this ulcer. Even before we stick that pair of forceps up into the patient's bone, we ask ourselves, does this person need imaging? What do you guys think? Do we need to get further imaging of this? Say we have a yes? No. You don't need further imaging. If you have any of the following, if you have exposed bone, if you have an ulcer greater than 2 centimeters, or if you can palpate bone, your diagnosis is done at that point. If the surgeons need further imaging for their operative management, that's a different issue. But in terms of diagnosing osteomyelitis, you don't need to get any further imaging. You don't need an X-ray or an MRI to tell you that this person has osteomyelitis. Jim?
So I find a lot of ulcers have origin of a foreign body stuck in there. So while you may not need it to diagnose osteomyelitis, you can tell, you still should get the film to make sure there's no foreign bodies. I've seen staples, thumbtacks, all sorts of stuff inside that you would never expect.
All right, that's a good point too. And the other thing is sometimes these have really sort of pretty aggressive cellulitis around them sometimes, and so getting a film to rule out gas in the soft tissues might be a useful thing as well. The recommendation from the IDSA guidelines, however, is that if you've got those 3 signs that you can stop and you don't need to do any further imaging. However, if you're suspicious for a foreign body or things like that, obviously at that point you would get further imaging. So let's say it's not quite so clear cut. You've got your clinical signs. I want you to know about those clinical signs. But if you don't have one of those hard clinical signs of the exposed bone, the ulcer greater than 2 centimeters, or the poked bone test, there's still a lot of people out there who have osteomyelitis underneath a soft tissue infection. So if we just had this picture here and we didn't have the other ones, what would be our next step in trying to work up the osteomyelitis? Get an X-ray. So radiology is going to be our next step. In terms of what we're going to find on plain films, the kind of things that we're going to look for that would be suggestive of osteomyelitis, this is pretty subtle, but I don't know if you guys can see down here on the inferior margin, there's the periosteum, and then there's a layer of radiolucent area right underneath that. Do you guys see that there? So that's called periosteal elevation, which can be a sign of early osteomyelitis. With very aggressive periosteal elevation, you get something called Codman's triangle. This is very non-specific. You can see this in any kind of aggressive periosteal lesion, including cancer, wound healing, fracture healing, those sorts of things. More often than not, when we're going to look at plain films and say that person's got osteo, we're going to see frank cortical disruption, which is what we see in the second metatarsal here on this particular patient. It's important to know about plain films is that you don't start to see changes until at least 7 to 10 days after the start of after osteomyelitis is already in the bone. So acute early osteomyelitis, not a useful test. X-rays are not a useful test. And because they're going to have basically no rule-out value at all. They're helpful when they're positive, but they're not very helpful when they're negative. This is also another little finding sometimes you can find. Anybody know what this is called? I do. It's called Brody's abscess. It's basically an abscess within the bone, which is pathognomonic of osteomyelitis. So it has decent specificity, meaning if you see osteomyelitis on the X-ray, then you can be pretty sure that you've got it, but its rule-out value is terrible. So what's our next step? Next test for us is going to be MRI. MRI, what we're going to see on MRI, and this is a T2 weighted image, is you're going to see that there's going to be hyperintensity in the actual cortical structure. Now, people do whole fellowships on soft tissue imaging, soft tissue MRI. So we're not expected to be able to read MRIs. But realize that this is the best test for diagnosing osteomyelitis from a radiologic standpoint. The sensitivity and the specificity are both pretty good. 90% of the sensitivity, above 80% of the specificity. Some other imaging techniques that you'll probably run across along the diagnosis of osteomyelitis is a nuclear bone scan. So what a nuclear bone scan does is it sends radioactive tagged glucose or white blood cells into the patient, and then you take an image to look and see where the radioisotopes are falling. This is very sensitive. If you have osteomyelitis, it's very likely it's above 90% sensitivity. The problem is that it is very, very, very non-specific. And almost always when we're looking for osteomyelitis in a patient who's got lower extremity cellulitis, they're already going to have inflammation in that area, and it's going to make a false positive test. So if somebody has a lower extremity cellulitis, a bone scan is not going to be a helpful test because it's going to light up in the area where that patient's cellulitis is already. And of course, it wouldn't be an emergency medicine lecture without ultrasound. Ultrasound has been studied in the diagnosis of osteomyelitis. From what I can tell from looking at the literature at this point, it's still very early, and it would not be considered standard of care to do a rule-in or rule-out test with ultrasound for osteomyelitis. What you do find sometimes is you can kind of see this little abscess formation next to the periosteum right here. All right. We talked about clinical signs. We talked about radiology. Labs. Most of us are going to order labs when we get a patient with osteomyelitis, but what is the usefulness of the labs? There's a lot of different labs out there that we can order. A lot of people talk about the ESR, the white blood cell count, the CRP. There's a lot of studies coming out about procalcitonin, some other markers. How useful are these things? Well, there's been a couple of reviews. All of them have been pretty crappy about what is the value of biomarkers in the diagnosis of osteomyelitis. And it turns out they're all terrible. WBC has no sensitivity or specificity. CRP is not very useful at all. ESR is the only one that is vaguely useful, and it's vaguely useful because if it's very highly positive, and when I say highly positive, the cutoff in these studies was all about 60 to 70, then it has a high positive likelihood ratio. But look for a second at that confidence interval. 1.6 to 17, that's a huge confidence interval. So take it with a big grain of salt. And then look at the negative likelihood ratio. The negative likelihood ratio, the confidence interval on that is 0.34, but it goes from 0.1 to 1.6, which if you think about what that means that within that 95% confidence interval, a negative ESR could be interpreted as saying that it's more likely to have the disease than not. So it's totally useless as a rule-out test. It's marginally helpful as a positive likelihood ratio test. Basically, labs are useless for diagnosing osteomyelitis. And I wouldn't ever make or rule out a diagnosis of osteomyelitis based on labs alone. So we have a patient like this, where we have all these signs. We have the hard signs. You don't need to look this up in order to tell you that this person's got osteomyelitis. So now we have to decide, what are we going to do with this patient? Are we going to give him antibiotics? I thought that was cute. Are we going to give them antibiotics or not?
If it's chronic, then you shouldn't in the emergency department.
So that's something you hear a lot. If it's chronic, you shouldn't give them antibiotics in the emergency department. Have people heard this before?
Is that chronic?
Sort of. That's sort of true. But the decision about whether to give antibiotics or not really shouldn't be whether it's acute or chronic. It should be whether or not they're septic. Now, did any of the juniors want to see if they can take a crack at the definition of sepsis? Because this is always a good review. SIRS plus a source. Okay, what's SIRS? Louder. What is it?
Heart rate greater than 90.
Okay.
White cells greater than 12.
10,000.
10.
Or less than.
Or
Okay.
bands.
Bands greater than.
10.
All right. Respiratory greater than, I think it's 22 or 20. And then there's another half to that one.
Or PaCO2 less than.
Less than 32. All right. Very good. And the temp is also less than 36 or greater than 38. These are our SIRS criteria. This is going to come up over and over and over and over again in the test. So make sure that you have this memorized stone cold. If you have SIRS with a suspected osteomyelitis, that patient meets criteria for sepsis. And at that point, the decision to make antibiotics is made for you. You should give that person antibiotics. Conversely, if the patient isn't septic, but they have osteomyelitis, there's a pretty good argument, but it's not backed up by that much research, but there's a good argument from an understanding of the disease standpoint not to give that person antibiotics. And you ask why? Why shouldn't I give? I have somebody who's here, they've got this chronic draining ulcer in their foot, they don't look septic, like that first guy in our first scenario. Why shouldn't I give him antibiotics? Well, the cheap reason is because the IDSA tells us not to. And the reason that they say don't give these people antibiotics is the theoretical decrease in yield on biopsy to get a culture of the bone. Everybody who's got osteomyelitis needs a biopsy, a tissue biopsy at some point, with the possible exception of people who have obvious hematogenously spread osteomyelitis. If you can get a positive blood culture, sometimes those people can avoid getting bone biopsies. But the rest of these people really should, the standard of care is for them to get a bone biopsy done. And there is a concern that giving antibiotics ahead of time would decrease the microbiologic yield. And they say this in their statement. The funny part is when they say this in their statement, they cite two studies, both of which The studies say that there was no statistically significant difference between people who got antibiotics ahead of time and people who didn't. So take that recommendation with a grain of salt. If you're on the fence, if somebody's like, I don't know if they're sort of like borderline septic, give that person antibiotics because you're probably not going to change the yield. But if somebody is really stable, really doesn't have any signs of sepsis, doesn't have any of the bad complications of osteomyelitis like an epidural abscess, then I think that it's reasonable at that point to not give antibiotics and wait for a culture.
I think that probably the best thing, assuming they're not septic, they don't have any indication, I think probably the best thing to do is have a conversation with the admitting team and see what they want. And then just document whatever your conversation said. This way they can't blame it on you if you took the one that they didn't want.
I think another caveat to that is just be careful in terms of a limb-threatening osteomyelitis as well. So the person may not be septic necessarily, but if you have local infection that you probably would give antibiotics to anyway, think about giving that antibiotics as well. I think ideally it'd be best if that person went to the OR, had the regiment, had surgical management right away, and then maybe they wouldn't need antibiotics emergently. That usually doesn't happen, and you can again talk to your consultant or the admitting team about that. But they don't necessarily have to be septic to have like a horrible cancer infection.
And you're not, and based on what I'm reading from the 2 articles of the NDSA guidelines citing for this recommendation, you're really not going to change the yield significantly by giving the people antibiotics. So if you're on the fence, you give them antibiotics. Another thing that comes up often is the yield of wound cultures for osteomyelitis. Don't culture wounds for osteomyelitis. If you have an external wound for osteomyelitis, the wound culture is going to be useless. It's going to misguide antibiotic therapy. The only kind of culture that this person needs is a bone biopsy or a bone-based culture, surgical culture. So blood cultures are helpful if the patient is septic, and blood cultures are helpful if you think the person has a hematogenous source of their osteomyelitis. If a patient's not septic, if they don't have a hematogenous source, if it's just like our guy in the first case who's got an osteomyelitis in the metatarsal but isn't septic, probably the blood culture is going to be very low yield. All right, so antibiotics, what are you going to choose? So this is where the difference between the hematogenous and the exogenous comes into play. The antibiotics that we choose for hematogenous are going to mostly be targeting Staph aureus. Staph aureus, streptococcal species, and the more common gram-negative rods. So in this case, because the hematogenous spread osteomyelitis to the spine oftentimes is accompanied by sepsis and oftentimes is accompanied by complications, we usually start off with covering MRSA, even if people are coming from the community. You don't have to be from the hospital to start MRSA coverage if you have hematogenous osteomyelitis. So the recommendations are to start with either vancomycin or if they can't tolerate it, daptomycin. Ceftaroline is an anti-MRSA 5th generation cephalosporin that we're seeing used a little bit more. They're probably going to begin recommending this for blood-based infections, but right now it isn't FDA approved for bloodstream infections. So just be aware that if you see that one pop up, it's not actually FDA approved for that. And then for the gram-negative rods, the 4th generation cephalosporins should be fine for somebody who has no other risk factors for pseudomonal infection. If they're a diabetic and they have a Lyme, then I would cover for pseudomonas at this point as well. When you talk about the polymicrobial infections in the lower extremity from the diabetic ulcers, we have to add coverage for 2 important things. One is pseudomonas, and that there is anaerobes. So what is it that we give most patients in the emergency room who come in with a complicated infection? We give them Zeccola. And honestly, that's actually a very good regimen for this disease. Because piperacillin has great anaerobic coverage, it has great gram-negative coverage, and it has good pseudomonal coverage. And the vancomycin will cover your Staph aureus and a couple of the other gram-positive stuff. You'll see a debate out there, this might come up, is whether somebody needs IV versus PO antibiotics for acute osteomyelitis. There is a Cochrane review that says that there is no difference between the efficacy of IV and PO. The big caveat to this study was that they said, as long as we know the bug and we know what antibiotic to give them, that it's sensitive, if we have sensitivities. So it kind of doesn't apply to us, because when we have somebody in the ER, we usually don't have cultures on them to begin with, at which point we want broadest coverage possible, which we're going to achieve probably with IV antibiotics. So if we're going to be putting somebody on a new course of antibiotics, especially if we're going to be admitting them, it makes sense to start them on IV antibiotics. All right, so who gets admitted for osteomyelitis? Well, honestly, it's very system dependent and it's very patient dependent. a lot of people with osteomyelitis are going to get admitted. And the things that absolutely need to be admitted. Somebody who comes in with acute osteomyelitis, meaning it's been less than a couple of weeks, that we're suspecting a hematogenous source, that there's a not a draining sinus tract at all, those people should get admitted. And the reason that they should get admitted is because you can potentially convert acute osteomyelitis to no osteomyelitis with IV antibiotics alone before committing a person to the salami treatment that we see with a lot of people's lower extremities when they end up with chronic osteomyelitis, which is like chopping off metatarsal after ankle to BK, etc. If people have a hematogenous source that's suspected in the osteomyelitis, they should get admitted because they should get admitted for bacteremia. They should get echo and other things like that that could potentially be life-threatening on their own. Anybody who's got any hardware at all, those patients need to get admitted because that hardware needs to come out. If you have infection around the hardware, then you've got to admit them. The surgical service that put the hardware in should be consulted in the emergency department, and ideally they should go to the operating room to get it out. If they're septic, they should go now. If somebody has already been on outpatient therapy and they failed, chances are they have a resistant bug or they need better bone penetration, they should get admitted to the hospital. And now the softer ones, if somebody's got poor follow-up and you don't think they're going to be able to get in to see the system, then sometimes it's reasonable to admit that person because these are people that if you discharge them with osteomyelitis, they can become septic, they can get limb-threatening osteomyelitis, and so that they should be followed up very closely. There's a couple of special scenarios. Sternal osteomyelitis always should get admitted. Sternal osteomyelitis is usually a complication of a sternotomy during cardiac surgery. So if you work at a cardiac surgery center, you will end up seeing those. They're not totally that rare, and they have a mortality rate that approaches 30% because people get mediastinitis from this. And patients with sickle cell disease who get osteomyelitis should get admitted as well because they get very sick from this. And it's usually, do you know what the organism is? Salmonella. Salmonella is the organism that sickle cell folks get in their osteo. All right, so who can go home? Chronic, not sick people basically can go home if you can get good follow-up. And this is gonna be really patient and really, really system dependent. So if we go back to our guy here at the very beginning of the lecture, we've got a guy who's got a month-long course, so it's chronic. He's not septic, and he's got normal labs which tell us that it's part of the sepsis criteria. Can he go home, or does he get admitted? What do you guys think?
He gets admitted for a biopsy, and then he goes home on oral antibiotics.
So that's reasonable.
Do we have anybody that performs the bone biopsy at downstate or county?
So Kings County, if it's in the foot, podiatry will do it.
At county, but not at downstate?
I don't know what it is at downstate.
I think IR also does it.
IR, I think orthopedics will reluctantly sometimes see these patients at downstate.
Because sometimes I know that with the osteo patients on the inpatient side, it's like, all of the patients I've had, they've always said we don't have anyone at downstate that will perform the bone biopsy. Or we used to, and we don't have that person anymore. I think that sometimes becomes a challenge to getting the actual bone biopsy.
I've got all mine at downstate, it's IR for the most
Yes, sir.
part. If they have a good pulse in the foot, you can get it sometimes podiatry, but most of it's IR and such.
Yeah.
I think, for my opinion, for this patient, the characteristics you're presenting, he's definitely a candidate for if you go home, good follow-up. I think the caveat for this, and it may just be using a stock image for the foot. If you look at the foot, you show that there is some localized signs of soft tissue infection as well. Some maybe wet gangrene, situation of the skin. So I think you're using a stock picture, but I think that the idea that you're presenting, I think the patient will probably come home. But just be careful, you do a good exam and look at local soft tissue infection. That person should get admitted if they're diabetic, if they have osteomyelitis.
Would you send them home with antibiotics?
Yeah, I think so.
Without a biopsy?
Yeah.
So I think there's a couple of ways that the point of asking this question is not to find the right answer because I don't think there is a right answer. I think it's going to be really patient dependent and person dependent. Like if somebody's really not sick, it might be reasonable if you can get them a podiatry appointment in the next couple of days to send them out so they can get debridement. But if you think that there's really bad cellulitis, if you see it around there, or if you think they're not going to be able to get seen very soon, then it's reasonable to admit them as well. Yeah, Dr. Super?
I think the question you're asking is, should you go in a box and then not have the biopsy because you won't know what the bug is? If you take your antibiotics and you pass and you do well, then you didn't need it. If you fail, chances are you're resistant, and the antibiotics won't change your biopsy anyway because you were resistant, so you'll be fine.
Such a long course of treatment.
What if the sugar is 330, no cap, whatever, but he's not really
I'm not sure how it's going to die.
That's complicated osteo.
Just think that they don't have a great reason to fight it. I don't know if there's any literature behind it, but I'm not sure how it is.
Yeah, and then that calls into question the person's, is there systemic signs? Is that why the sugar's in control? Or is the person not adherent to their medication and they're not a great patient to separate out the problem? So yeah,
I imagine this has to be there. I mean, that's the one thing you told me about it, he's diabetic.
He is diabetic, but not every diabetic with osteoyelitis and somebody who's got a bad cellulitis does need to come in. What I was thinking is, whether you admit them, whether you give them antibiotics, I don't know. It's going to depend on the patient. It's going to depend on the system. It's going to depend on their follow-up. It's going to depend on how good their access is to care. So we've been through a lot of stuff. We've talked about what is osteomyelitis. We've talked about how do you diagnose osteomyelitis. We've talked about how do you treat osteomyelitis and who gets discharged. So I want to just go over it one last time, summarize for you. So the first thing to do is to suspect osteomyelitis. Who should you suspect osteomyelitis in? So any diabetic with a soft tissue infection. You should suspect osteomyelitis. That thought should cross your mind. Does this person have osteomyelitis? Do I need to look it up? Anybody who's got back pain that sounds a little fishy. So anybody who's got back pain and a fever. Anybody who's got point tenderness over a vertebra. Anybody who has back pain and has a risk factor for bacteremia. Either they're an IV drug user, they have an indwelling line, they have known endocarditis, they have a new murmur. Those people, you should think about vertebral osteomyelitis. And then anybody who's had a surgery or had a trauma and has persistent pain after the usual period of time when you would expect the pain to be for their injury. So if you have somebody that's 2 weeks out from surgery and they say, you know, my pain's just getting worse or it's not getting any better, that's somebody you should think about osteomyelitis in. Diagnosis of osteomyelitis, use your exam skills first. If you can see bone, if you can palpate bone, if you have a big ulcer, you know your diagnosis at that point, that it's osteomyelitis. And you don't need to call in an MRI in the middle of the night to diagnose that osteomyelitis. You don't even need to get an MRI right now. You can admit that patient with the diagnosis of osteomyelitis and let the inpatient team decide whether or not imaging is further for the actual management. If your exam is equivocal, then radiology is the next step. If it's chronic osteo, it's reasonable to get an x-ray first, realizing that if it's negative and you have a high suspicion, you're going to be going to an MRI. If it's acute osteo, realize that it's very unlikely for that x-ray to be positive if it's less than 2 weeks, and so it's reasonable to start with an MRI at that point. If it's spinal osteo, it's always good to get an MRI as your first test. It's not the sensitivity of a screening plain film of the spine for osteomyelitis is very, very low, less than 10%. And almost always you need to get an MRI of the spine to characterize where the actual abscess formation is and if there's any formation of epidural abscess or something like that. Labs are not useful. The only one that's vaguely useful is ESR as an indicator that it's more likely, but none of the tests are useful as a rule-out test. So if anybody tells you, oh, this person doesn't have osteo because they don't have a white count, they don't have an ESR, it's not true. None of them are useful for rule-out tests. And the people you admit are the ones who are sick, the ones who are acute, and the ones who have complications. If they're septic, give them antibiotics. If they're not septic, you can consider waiting. It's reasonable to start with antibiotics. And special thanks to Dr. Regan, Dr. Willis, Dr. Hassel, and my family.